early. We'll all wake up together and hopefully by the end of this, we'll be in the swing of it. But as Brooke said, I'm Emily, one of the clinical education managers here at MedVet. If I don't put a slide on here, I'll forget to talk about myself and actually tell you who I am. So that's why you have to stare at this. So I've been in critical care basically since the start of my career and ended up ventilating since the start of my career. And it turns out it's one of my favorite things ever. So I'm really happy to be talking to all of you about it today. This is me in an oxygen cage with one of my vent patients that had just come off the ventilator, and I spent an entire shift in there with him. And it wasn't a very nice dog, but it's still a fond memory, and I'm glad I got him home. So in terms of my areas of expertise, this is definitely it. This has been the focus of my career for about 7 years now. And if it's the only thing I could do, I would do it. So today we have massive subjects to talk about. And I know I'm going to have you captive for 2 to 3 hours here. So I don't want this to get too boring. But we're going to be covering high flow ventilation or high flow oxygen therapy. We're going to be covering mechanical ventilation, which is going to be the bulk of what we're going to talk about today. And then brief demonstration with the PleuraVac. Got some resources for you. That's probably going to be the simplest, but also very intimidating in an emergency. So I want to make sure everybody's comfortable setting up and monitoring with the PleuraVac. So especially with mechanical ventilation, just as a disclaimer here, we're not even going to be scratching the surface of this therapy. We could be here for days talking about it and still not get through it. So I'm really just going to be focusing on introducing the ventilator to you and talking about your role as a technician providing nursing care for these patients. So especially with all of these subjects, my hope is that you don't come out of this having memorized everything I say. My hope is that you kind of meet me where you are. So if this is an introduction to you, then I hopefully have demystified it a little bit. If you have some experience with any of these modalities, then hopefully we can spark some conversation and dig a little deeper. I know it's been a minute since your last vent case, so maybe I jog your memory on some things, and then it becomes easier to kind of grab out of your brain the next time. So that being said, I'm very happy to keep this casual and conversational. This is not about me, this is about you. So I don't care if you interrupt me, you can raise your hand, you can just talk over me, whatever it is, ask questions. And then the other disclaimer that I want to mention on that note is I'm going to be showing you a way to do something or a couple ways to do something. It's not the way. There are tons of different ways to approach any of these modalities. And so if you've seen something different, if you have experience and your preference is something different, doesn't mean that you're wrong and I'm right, or I'm wrong and you're right. I'd be happy to talk about it if you wanted to speak up and talk about the different way you do things and hopefully narrow in on what you guys practice here in Boise. But just keep it casual. I'm happy to just make this a conversation and we can really focus on where you as a team want us to go. But if nobody speaks up, I can just charge ahead with my presentation and that's fine too. Okay, so to start us off, we're going to talk about high flow oxygen therapy. And that is because it's sometimes looked at as an intermediate step between traditional oxygen therapy and ventilation. That's not always the case, but I think especially in veterinary medicine where finances are an issue, we use it that way. So we're going to start there and then move on into ventilation. But before we really get into your machine, what is high flow oxygen therapy? Why is this the big new thing in veterinary medicine? I mean, most MedVet hospitals have a vapotherm unit now. Well, it provides heated and humidified oxygen and air to patients at really high flow rates. And that does a couple different things. So the dry forced air that's potentially not even cold that comes out of an anesthesia machine or a Snyder oxygen cage, it's really irritating to the respiratory tract. So patients tend to tolerate the high flows that come out of this because it's heated and humidified. It's not going to irritate the respiratory mucosa and cause further inflammation. And the high flow, obviously in the name, is going to be a really important component of this. Just went ahead. So at the flow rates that we can achieve with these vapotherms, which is up to 40 liters per minute, we can do a couple different things for patients, which we're going to talk about in a lot more detail. But one of them is we can really force open the alveoli in a way that only ventilation was achievable with us before. It's called continuous positive airway pressure. And that is a game changer for patients who may not need the ventilator, but aren't going to do well in an oxygen cage. It's really easy. It's really simple, and easy to monitor as well. So this has been, HiFlow has been a really, really important therapy introduced to veterinary medicine that I think more and more people are getting on board with over the last few years. We do need to administer it through very specialized cannulas in order to tolerate those flows. So we've got the whole setup here that we'll go through. And the other big advantage to HiFlow versus traditional oxygen therapy is the inspired oxygen, so FiO2, the amount of oxygen we provide our patients, can be adjusted. So yes, we can adjust it on a Snyder, but really only up to 40, 50%. If you've got a beefy one, maybe you can get to 60 or 70. But we can go anywhere from room air to 100% on this vapotherm. So in patients that might have had to be intubated and on an anesthetic circuit in the absence of a ventilator and risk oxygen toxicity, it's no longer an issue, this vapotherm. So what types of patients benefit from HiFlow? A lot of disease processes, I could rattle them all off to you, but the long and short of it is if your patient has failed traditional oxygen therapy, they're a candidate for HiFlow. So what does that failure look like? Well, if they're receiving oxygen and their pulse ox is still less than 93%, we consider that failing traditional oxygen therapy. And if their PaO2, which we'll talk about more later, but it's a value we get from an arterial blood gas that looks at total oxygen levels or the pressure of oxygen in the blood, is less than 70%. Realistically, if we've got a patient in trouble in oxygen, a pulse ox is pretty difficult to get, either with patient compliance, like that respiratory, that oxygen hunger really stresses them out. I'm sure you guys have all seen, you go in and mess with them and they are not having it. And also, you know, for varying reasons, can we even trust that pulse ox? And if we can't get a pulse ox on them, we're definitely not getting an ARC gas. So the long and short of it is if their respiratory signs don't change or they get worse, during the first 30 minutes of oxygen therapy, appropriate oxygen therapy, not just flow by, then they are a candidate to be transitioned to HiFlow. So I wanted to shout this out. I will be sending this to Brooke and she can send it to you guys, but this is a really great study for those of you if you're wanting a very thorough but approachable introduction to HiFlow. So I just wanted to shout this out as a resource for you guys if you want to dig a little deeper. But we're going to look at a table from this study that does a direct comparison of HiFlow and traditional oxygen therapy. So we can kind of assess the benefits and disadvantages that we might be facing with any of these. So this is a table of all the types of oxygen therapy that might be available to us short of ventilation in our varying hospitals. So the first being flow by oxygen, we can really only get about 25 to 45%. And to get that 45%, we've got to have their face really got to have that oxygen tube really shoved into their face, right? So it's not going to be a great oxygen option if we need really high flow rates or high oxygen levels, and it's not typically tolerated by patients very well. Moving up, we have an oxygen face mask, which we can really only achieve about 35 to 45%. So again, that's might be enough for some of your patients, but it's not especially significant for your pretty sick kiddos. Then we have our oxygen cage providing 50 to 60%. I've definitely worked with Snyders that can't even get to 50, and worked with Snyders that we've aftermarket rigged to get to 80. But for the most part, you're going to be at 50 to 60%. And there are really big drawbacks with an oxygen cage as well, right? Every time we open those doors, that concentration tanks. We don't have direct access to our patients. And if they're sick enough to need 60% oxygen, we should probably have pretty good access to those patients. So they're great in the context that they exist, but not for your super sick guys. Next, we have nasal cannulas. This is probably my preferred method of traditional oxygen therapy. Depending on the flow rate, we can get anywhere between 30 and 60% oxygen with these guys. And we do have patient access with this. But what if we need a little bit more? That's when we get into HiFlow. So with HiFlow, we can achieve anywhere between 21 and 100% FiO2. And we get really specific benefits from HiFlow that we don't get from other types of oxygen therapies, including the washout of anatomic dead space. We can achieve PEEP in some cases. We'll talk about all of this more in detail, I promise. And that humidification and warming of inspired air ends up being really, really important. One thing I wanted to call out as a potential drawback that I have definitely seen in practice is that it can delay transition to the mechanical ventilator. If a patient needs a ventilator, there's no substitute for it. However, we live in the real world, and not everybody, every owner is going to be willing to jump straight from admission to ventilation. So the delay is understandable. I'm not calling anybody out, but it can delay the ultimate therapy that the patient needs and then contribute to worse outcomes. So I just wanted you guys to kind of be aware of that drawback. I know you won't necessarily make the decision as to whether a patient goes on the ventilator, but you're all advocates. And we'll talk about what signs to look for when a patient needs to be on a ventilator versus HiFlow. And just want everyone to be aware that that delay is certainly possible, and we should make sure that we're keeping an eye out for it. All right, so to look at those benefits in a little bit more detail, we first have the washout of anatomic dead space. So what does that mean? Why do we care about it? Well, dead space is going to refer to the places in the lung where gas exchange doesn't happen. So we've got the distal trachea, we've got the bronchi, we potentially have lung lobes that aren't perfused. And these serve as CO2 reservoirs that are then rebreathed in patients that are in respiratory distress. So we've all seen it, they're breathing really rapidly, and they're not necessarily taking really good deep breaths, right? So that can cause the inhaled gases to not really come from the outside, they're coming from the inside. You're taking really, really teeny tiny breaths. You might only get the air from your trachea into your lungs. And if that air in your trachea contains a lot of CO2, not a lot of oxygen, then it doesn't really matter how much they're breathing. They're just getting that CO2 rich air and not the oxygen rich air. HiFlow can blow that out. So because it's going at such fast flow rates, it's essentially circulating air through the lungs, whether or not the patient is actually inspiring or not. So we're essentially flushing that CO2 out of the dead space. So those little crummy breaths are still getting a lot of oxygen, and that patient, as they proceed to oxygenate, will calm down, take deeper and deeper breaths once we get our sedation on board and we get our treatment plan together, they'll continue to improve. So I found this to be a really useful benefit when we are working with brachycephalic breeds who are experiencing an upper airway obstructive crisis. So not the ones that are fully obstructed, so those need to be intubated, right? But the ones that are either just extubated and trying to figure out how to breathe again. Never seen any patient breathe as lazily as a French bulldog or a pug. They just decide as soon as you start doing it for them, they're never going to do it again. So we can transition them off of intubation with HiFlow. But for those patients that come in not fully obstructed, we can put them on HiFlow, get a washout of that dead space, and give them some access to oxygen. LARPARs are another good one for this. I wouldn't recommend this necessarily for your dynamic airway disease, so your collapsing tracheas. Yes, it's an upper airway obstruction. But any sort of forced air, even if it is heated and humidified, is just going to make that worse. So I would say that's going to be a population of obstruction that you probably wouldn't put on HiFlow. But for your brachycephalics and your LARPARs, it's awesome. And again, really good way to avoid intubating and ventilating. And then we have the PEEP effects from HiFlow. Now, this isn't an effect that we achieve in every patient under every condition, but it's an important one to talk about. So PEEP is going to refer to positive end expiratory pressure. We can also call this CPAP, which is continuous positive airway pressure. And it basically means that once that patient exhales and they're at the end of exhalation, there's a little bit of pressure maintained in those airways. So when I exhale, the pressure in my airway is 0. When our patients exhale, it's the same way. This machine at really high flow rates can keep a little bit of that pressure. And what that does is it helps open up alveoli, so those little gas exchanging units that line our lungs, helps open them up and make them more available. So we have more functional units participating in gas exchange, which is going to cause better oxygenation. So that's going to be a really big benefit for your congestive heart failures that go on high flow, where they have that pulmonary edema and those collapsed alveoli. And we can blow those open if we can achieve PEEP. Now, we don't always achieve PEEP. We do have to run it at 1 to 2 liters per kg per minute. Not every patient's going to tolerate that. And honestly, most of the time when I've thought that I've seen PEEP, it's been at about 2 liters per kg per minute. And if the patient is panting or open mouth breathing, we're not going to be able to get it. It requires a somewhat closed airway. So the mechanism by which this allows us to generate some sort of PEEP isn't actually fully understood, but it's thought that we're putting more air in than is coming out in a very controlled way. And so that's helping. It's not certainly going to be the only factor, but if they have their mouth open, we've got a lot more air escaping despite really high flow rates, and it's just going to passively leave, and their pressure is going to be at 0 at the end of expiration. So we don't have an actual way to measure whether or not a patient is going to achieve PEEP on the high flow. We just don't have that capability to monitor that if they're not actually intubated. So we're trying for it, potentially sedating for it if our patients are open mouth breathing, but we don't actually know if we're achieving it. We're just flying by the seat of our pants, as we always do in vet med, and looking at clinical signs and hoping that our patients are improving. So we've talked about humidification and warming. Really, really good benefit to high flow. In fact, probably the main reason why it actually works, why we can force air into these patients at those massive flow rates, is because we're not forcing cold air into them. So cold air, we talked about how it can cause inflammation and damage to the mucosa within the airways. It can also cause bronchoconstriction. So essentially narrowing of the lower airways. We have smaller airways, we have less air going to those distal lung fields, and our patients don't oxygenate as well. So avoiding bronchoconstriction with these forced air modalities is quite important. And additionally, that humidification can improve mucociliary function, which is going to allow for better clearance of mucus. So our patients will cough up their pneumonia more readily, or reduce the likelihood of it developing if they don't already have pneumonia. Pneumonia is going to be a risk of any of these modalities, by the way, especially ventilation, but for our long-term high flow patients, because again, we're forcing things into the lungs that shouldn't necessarily be there. It's very irritating, causes a lot of damage. So anything that can reduce our chance of a developing pneumonia, it's a really big bonus. Got a patient sick enough to be on high flow, they really don't need another disease on top of it. So we do have some other benefits that aren't necessarily going to be measurable, but what I find to be very, very helpful with high flow, we get full access to our patient, complete access. So they don't have to be, locked away in an oxygen cage. Even with the ventilator, they're on a table and they've got all of these things on them. High flow is super simple. It's just nasal cannula, and that's it. Kind of a short leash from the vapotherm to the patient, but it's a manageable one. They can mostly be awake as well. So some patients are going to need sedation, either to manage their respiratory signs or because they're intolerant to the cannulas or the therapy itself. But a lot of them can be very awake. Sometimes TORB is all you need. So another benefit, especially for those pretty compromised patients, is we don't have to worry about walloping them with a massive sedation or anesthetic protocol to maintain them on these more aggressive therapies. Just give them a touch of TORB whenever they get anxious, and that's it. That FiO2 titration, so the fraction of inspired oxygen titration we talked about, it's another really big one. I added that here. I do want to touch on this. So when we say 21 to 100% on the FiO2 titration, that's what's being delivered to the patient, right? But because this isn't a closed system, they are getting a little bit of outside air mixed in with that. So just as a side note, when we have this at 100%, they're not actually getting 100%. It's usually closer to 80, 70 or 80, depending on your flow rate, the size of your cannula. But that can be very, very important in reducing Oxygen toxicity. We have patients on 100% oxygen, really anything over 60% oxygen for extended periods of time. We start getting damage and atelectasis as a result of those high concentrations of oxygen. So as opposed to some of your traditional modalities where you have to be very aggressive with your FiO2 to compensate for other things that this HiFlow is able to achieve without those really high concentrations of oxygen. We can get our patients down to a safer level of oxygen and not have to fight toxicity on top of everything else. And then, of course, relative to mechanical ventilation, it's super fast to get them on HiFlow. You have a sick patient who needs HiFlow, give them a little sedation, pop the cannula on, throw a couple sutures in, and you're good to go. We can always like shore up the things that we missed later and like really secure those, but we can get patients on HiFlow within 5 or 10 minutes. Mechanical ventilation is a process, as we'll see. Very, very easy to monitor. You don't have to do a whole lot of special monitoring with these guys. We'll go in depth a little bit later on what that monitoring looks like. But while it might look intimidating, really isn't too bad. It's just like monitoring any other respiratory patient. It's very cost effective for owners, so they're more likely to buy it. And that's a really big one, because previously, before we had HiFlow, and it was just like traditional oxygen cannulas or an oxygen cage, or you're looking at, depending on where you live, 40,000, 60,000, 80,000 dog. People don't really go for it. The traditional oxygen doesn't always work in those cases, and ventilation is insanely expensive. Now we have a nice middle ground to offer them, again, for those patients who are suitable for it. Okay, so we are going to spend some time on setup for all of these things at the end of our talk here. But I do want to spend a little bit of time introducing you to some of the resources I brought and how to use them when we're talking about setup. And then give you guys some of my tips when it comes to setting up this HiFlow and talk about the main things. So this is a resource that I developed with a criticalist in Silicon Valley to try to make this as simple as possible for the teams, with the understanding that if you're starting this machine up, it's an emergency. And we need something very clear and easy. So we have, to start out with, cannula sizing guide. So the first thing we're going to be doing is we're going to be fitting these cannula to our patients. And we have recommendations here for what those cannula sizes look like. Now, not every location carries every size. I think there are up to 6 sizes of cannula available. Most places are going to carry 3. But this is a really good recommendation. And you can see an example of the size difference. I mean, these guys are teeny tiny, and these guys are really big honkers that most patients aren't going to even fit. So you can use this weight-based guide to kind of get you started in sizing the cannula. I will say brachycephalic breeds, you're probably going to size down. But we'll talk about, when we set up the HiFlow, about another trick that I have for those guys as well. So this is on that guide. So if you're just like staring at these things and you don't know which one to choose, you can go ahead and start here. Now, with sizing, there's a very, very important aspect that we have to remember as we're placing these cannula, and that's the 50% rule. So that cannula cannot obscure more than 50% of the area of the nares. Remember, we're forcing air in at these incredibly high flow rates, and that air has to go somewhere, or we're going to cause trauma to the lungs called barotrauma, or trauma from pressure. So we need that air to be able to escape. So we don't want cannula that are too large. So this is what it looks like. Yes, Brooke won't be surprised, but I actually measured these circles. This is exactly 50% the area of this big one, and that's what's going to look like in the nares. You don't have to measure it. You don't have to be perfect. We just have to make sure that there's a place for air to escape. Now with brachycephalics, as I'll show you, because they tend to have teeny, teeny, tiny nares relative to their body weight, which means relative to their lung size, it can be really difficult to find an appropriately sized cannula for them. You either have to go really small, where the prongs are really close together and they are not going to fit the width of that nose, or they're so small that we can't deliver the flow rates that we need to through them because they're pediatric or neonatal circuits. So what you can do Sounds really janky. But what you can do is you can find a large size and you can essentially melt off the end of one of those prongs with a lighter. And the plastic will kind of glue together and seal off. And then you got one big one and one totally open nostril. And that tends to be the most successful way to size for brachycephalic patients that have really stenotic areas. That way you can achieve your flow rates. You still have that 50% rule. And the patients are more comfortable not having sized to like a teeny tiny cannula that isn't going to do much anyway. So this is going to be the most important thing that we consider when we are sizing those cannula. Now, in terms of placement, a couple other things to consider would be that we always want to make sure that those prongs are curving downward. They're directing air down into the trachea. I have seen it more frequently than you might believe that they're placed upside down. This, again, patients going on this therapy are really sick. They're emergencies. I can forgive people for not necessarily like worrying about every little detail, but this is a detail you want to worry about. Making sure those are pointed downwards. They're pointed upwards. All of that flow is going to the top of the nasal mucosa. It's going to make your patients really uncomfortable. It's not going to be directed down into the airways, which is not going to allow us to achieve any of that CPAP that we talked about, if that's what we're going for. And it can just cause a lot of irritation and patient intolerance, which is going to mean you're going to need to sedate them more, et cetera, et cetera. I have seen this frequently enough that I recommend at the start of your shift, just making sure that they are pointed the right direction. I've seen patients, like kind of get them out and then they are resutured in upside down because the patient's fighting and they're just all, worked up. Definitely not throwing anybody under the bus here, but that's going to be super important. And we can leave our nasogastric or nasoesophageal tubes in place. So another common question that I get is, does that need to come out? No, it does not. No. Not necessarily. That's a good question. If the NG tubes usually aren't so big that they're obstructing like a significant part of the nares. If it's a huge one, like in a cat, for example, I don't have a lot of information about high flow in cats, but it can be done. But a cat, that's going to take up the whole nostril, right? I might size down in that case or do the brachycephalic trick, but I would have to probably assess my patient's tolerance of high flow prior to making that decision. So when we're talking about securing the cannula, I have found that there's really no right way. It is very dependent on your patient's anatomy. And as we know, we have everything from like completely flat-faced or even like inverted-faced patients to our normal patients like this setter here. So it's really just going to be about what is going to make the most sense for your patient's anatomy and the type of cannula, the size of cannula that you used. So I defer to your judgment here. It's a lot like placing an NG tube. Sometimes we suture it above the zygomatic arch. Sometimes we go above the bridge of the nose. Really is just kind of vibes. But a couple things that I do find helpful is suturing them as they kind of go past the nares. So kind of in the place where you would suture an NG tube. Now I see people finger trap these a lot. I have not found that to be necessary. If it makes you feel better and it makes you feel like, yeah, that thing's not going anywhere, great. But if it's an emergency and you just need to get a patient on high flow, it's probably not worth your time. If you find you need it, you can come back and finger trap later. There's nothing wrong with it. It's just a time suck relative to just throwing a couple quick loops in. So don't compromise your patient over the finger trap. I don't think it's that important. We can also make a little tape bridge, as you may have seen, to kind of help them rest comfortably over the nose and not slide down the face. And then we can suture them over the zygomatic arch, again, to make sure that they're not sliding down the face. Now these cannula, as you'll see, have a little like, I don't know what you call it, like a little pulley thing so you can tighten them against the head. That will help them stay up so that this, the path behind the head is clear. You don't have to suture it all the way back. And if you have a really active patient or a patient who's really intolerant of the high flow, you can also suture that little bridge to the top of the nose, or you can make other tape tags. So again, it really is just all about what you feel that patient is going to need and what their anatomy is telling you. It doesn't end up being too difficult. You don't have to make too much of a puzzle out of it. All right, so going back to our setup guide here, next thing I want to talk about are cartridges. So we have two different options for our HiFlow cartridges, which are going to come in these bags that look like this. So what you'll notice is we have a low flow and a high flow option. Now low flow, that's still high flow oxygen. So I don't know why they couldn't name it something else, but there we are. So low flow in people. So low flow is going to come with a speed limit on how fast we can deliver that oxygen. So we can go up to 8 liters per minute on the low flow. So it's really only going to be suitable for your smaller patients. Really, we're going up to about 2 liters per kg per minute. So as soon as a patient is over 4 kgs, we should probably be putting them on a high flow cartridge. Our high flow cartridges are going to go from 5 liters per minute to our maximum on this machine at 40 liters per minute. So most of your patients are going to be on a high flow cartridge versus a low flow cartridge. Your cats and your teeny tiny dogs are going to be on low flow. I will show you, so when these cartridges are open and they're out of the bag, they look almost identical. I'll show you how to identify where to see whether it's a low flow or a high flow cartridge. And I say that because some hospitals will reuse the cartridge between patients for up to a month after opening. Some hospitals don't. Whatever your protocol is here, feel free to follow it. But if you are going to reuse the cartridge, you certainly want to date it. But when you go to start a new patient on an old cartridge, you want to know whether it's low flow or high flow.
We don't reuse them in this hospital.
That makes it so much easier.
So if they become like short on supply, we might have to cover that, but currently they're not being reused.
Perfect. Then you don't even have to worry about it. So in terms of the startup and shut off sequence, I'm not going to go into this in detail right now because we will do it when we get this machine up and running. But I did want to show you this guide. So this is our setup. And you're essentially just following the rainbow. We tried to make this as absolutely simple as possible. And you'll see that startup can fit on one page with graphics and big font. So don't be too intimidated by it. What I want to point out here is that all of this does need to be done in this specific order. So try not to get ahead of yourself. If you're doing it for the first few times, you don't have that muscle memory yet, please reference the order in which this needs to be set up. It does make a difference. You're not going to break the machine or anything, but it's going to give you some trouble that you could have avoided. And then shut off needs to be done in the reverse order. So we've provided that here for you on the back of our startup guide. And again, it's just a very simple one-page thing. Brooke has the file, so if you guys are interested, she can send that out.
I will share all the things.
Yep.
We'll also make laminated versions of all this stuff to like stay with the machine, and we'll have develop very specific SOP for all of these things.
Yeah, and I did look at the guide that you guys have, and it's great, right? It's going to be hard in an emergency to follow, but when you've got a patient on high flow and you've got them set up and you're autopiloting a little bit, I'd strongly recommend reading that. It's a really nice bullet point outline of what we're doing, why we're doing it, how to monitor them. So that's a really, really nice reference to have as well. This is hopefully going to be a little bit easier for those emergencies where you're like, oh, I haven't done this in 6 months. Like, what do I do here? So with all of that being said, essentially my flow when I'm setting up high flow is I start the machine up and then I place my cannula. And that's because this machine is going to take a minute to warm up. Usually it's under 5 minutes, but sometimes it can take a little longer. So I like to have it sort of cooking in the background as I'm placing my cannula. That means that I have to set my settings in order for that machine to get there. So if it's an emergency, you don't necessarily have a clinician or a criticalist staring over you, telling you exactly what they want. It doesn't mean that we can't set it up. We still want to make sure that this is set up. So what do we set it at? Well, our flow rate is typically going to start between 0.5 and 1 liter per kg per minute. I'm glad you're here, Bridget. So if you disagree with anything I'm saying, you can chime in for your preferences. This is usually where we're starting. And then we're gonna work up the support if our patient needs it, but we're not gonna go full blast right out of the gate. So essentially, whatever their weight is in kilograms, that's usually what I'm starting at, because in my mind, that's simple. I don't have to do any math, even if it's dividing by 2 sometimes. That's gonna make me pause for an embarrassing amount of time.
Can I just make one comment? Very oftentimes, that's where we're like starting our settings at, or if they're in a real crisis, sometimes we'll jump up to the 2 liters per kg per minute. But usually when we're starting them on HiFlow settings, I've got it set to 5 liters per minute and just kind of starting there. And then within the first minute, 2 minutes, I'm escalating them up and kind of getting them used to a higher flow rate. So you're not presetting it at a 25 kg dog's not going to get set at 25. They're probably going to start out at 5 in the first minute or so, kind of gradually you're adjusting that dial and giving them more and more flow up to their 20, whatever it is. So,
Perfectly. Yeah. All right, and so our temperature, this is going to refer to the temperature of the air that the machine is going to deliver to the patient. We want that at body temperature. This is going to be in Celsius. We're going to go with 37 degrees. Now, this is the piece that takes the machine a little bit to warm up. And to Bridget's point, if we're going to blast them with cold air, they're not going to tolerate it. And if they're not going to tolerate this therapy, it's not going to work for them. So making sure that we give this machine plenty of time to achieve that temperature is going to be very important for patient tolerance. You're going to get better outcomes there. And then usually we're starting at 100% FiO2 and walking back down. So in an emergency, sounds like we're starting at 5 liters per minute in most cases, regardless of their weight, and amping up. But you can set your FiO2 for 100 and your temperature for 37. All right, in terms of monitoring these patients, if you've been monitoring patients in respiratory distress, you're well equipped to monitor a patient on HiFlow. So it's going to be really, really similar. We're following the same parameters. We're doing the same type of serial monitoring with the respiratory rate and effort, pulse ox if our patient's going to tolerate a pulse ox. Yeah, you can do arterial blood gases, but sometimes that's overkill in these patients. Even if we're thinking that it might need to be transitioned to a ventilator, we're not necessarily going to use a bunch of numbers off an ART gas. We're going to be looking at our patient and the way they're responding to therapy. So you will see some people who will do blood gases and some people who don't. It's not wrong. Just might be a little bit excessive for the vast majority of your patients. And considering that these patients are awake and have a respiratory disease, stressing them out for an ART gas that's not necessarily going to change our plan isn't typically worth it. Whether or not it's on your treatment sheet, making sure those cannula are placed appropriately at least every 4 hours will be really important. Patients can dislodge them. Like I said, they can be installed in different directions. We want to make sure that we're evaluating that because that is going to be the key piece that makes sure that this therapy is actually delivering those flow rates we need. And we should expect clinical improvement to be observed within 1 to 2 hours of initiation. Usually it's going to be faster. But if we're at the 1 to 2 hour mark and we haven't seen an improvement, it's probably not going to happen. Most of the time we see this within about 30 minutes. And then with patient care. So in addition to respiratory parameters, we actually need to be monitoring, just like with any other patient, our patient's comfort. It's especially important with HiFlow because we might experience discomfort due to really aggressive flow rates. If our patients are uncomfortable, they might start panting, they might get agitated, they might try to pull their cannula out, and we need their tolerance for this to be effective. But we can also see in dogs aerophagia secondary to HiFlow therapy, and that's uncomfortable. You got a big old belly of air, big distended stomach. They're going to show you. They're going to be restless. You could see abdominal distension, you might not, but it is certainly something that we want to look out for. And usually patient comfort is going to be my first sign that that aerophagia might be setting in. And then, of course, as we talked about, you might need mild sedation for tolerance of the cannula. But if you're needing like really heavy big guns, we might want to assess whether that's placed properly. We might want to think about different flow rates and try to figure out what is exactly making that patient uncomfortable. Because this is heated and humidified, they should be pretty tolerant of it in most cases. I will say that doesn't hold true for cats. I haven't done a lot of cats on HiFlow. Like I said, we don't have a ton of information about it either. But they don't like it, as with most things. Okay, so complications. We do know that barotrauma, so trauma secondary to high pressure in the lungs, pneumothorax, and pneumomediastinum have been described in humans. Haven't really seen that in the animal population yet. This is still new to us. We have a limited amount of studies, but it hasn't been observed to my knowledge. However, we do see aerophagia, like I mentioned. So if we get aerophagia, that big gastric distension, that is also, if it's big enough, going to impede that patient's ability to ventilate. So it is something we need to look out for. Again, progressively distended abdomen and restlessness. Those are the things that are going to trigger me into it. And then we want to make sure that we are keeping an eye on our FiO2. So oxygen toxicity in patients maintained at greater than 80, sometimes greater than 60. It really depends on who you're talking about and for what amount of time. But we don't want to leave these guys at 100% for extended periods of time. All right, that brings me to the end of the HiFlow section. So what questions do you guys have? Yeah.
I know you mentioned atelectasis earlier. Sometimes we did have a HiFlow patient who was pretty aggressive that ended up needing like a Dexmed CRI or maybe a PleuraVac CRI, I couldn't remember, but he was pretty flat most of the time. And we were only rotating him like every 4 hours. Is that something just with your expertise that you would maybe bump up and have them rotating a little bit more? Maybe doing like a left lateral to a sternal to a right lateral, or?
What I would advise in most circumstances is that they stay in sternal and you rotate hips.
Okay.
In order to ward off that atelectasis. Now, for every disease process that might not be appropriate, but for most disease processes, that's going to be your best bet. It's going to allow better ventilation of both sides of the thorax. Even if you are rotating every 4 hours, it just can be more helpful. Not always the best for patient comfort though. A lot of patients want to slide into lateral, in which case every 4 hours I do think is appropriate.
Okay.
And sometimes that positioning also changes based on underlying disease process, like if we have a severe right-sided aspiration pneumonia, and they're like really not using that portion of the lungs, or we get better oxygen saturation when they're on that side. Sometimes we try to balance the sternal versus that lateral so that we're using the up lungs, at least initially while they're kind of in crisis mode. So,
Yeah. Anything else?
Does that temperature ever change, or is there a scenario that we would ever have to do?
I've never changed it. Bridget, would you have a scenario that you change it on?
sometimes if I'm questioning whether my patient's tachypnic because of their fever, sometimes I'll like try and artificially cool them by like 1 degree Celsius or 2 tops. Just to see if I can get that temp down, if that can help their respiratory rate, but for the most part now. Or if I have like a really agitated, like bulldog that we're struggling to keep cooler, sometimes I'll drop that temperature a little bit. Like we're trying to balance keeping their airways warm and not cooling them, but also like trying to prevent the bulldog from really getting like a hyperthermic crisis while on it.
What else?
I'm gonna start with that. So, the way you do the single pill, problem for me.
Oh yeah, I have a guide with pictures that I can send as well, but it just sounds so terrible when you describe it, but you're essentially taking a lighter and holding one prong over the lighter until it melts and seals itself off. And then you have a single prong cannula. Yep. Yep. And really just for your brachycephalics, maybe a teeny tiny cat. But it's if you can't find the appropriately sized cannula and you're obstructing too much of those nares, you can use just a single cannula.
And the goal there is to obstruct that cannula without putting something in it that we could then force it to the dog. Because we're not like putting tape over it or like shoving something in the opening, because
Yeah.
in theory we're creating a very high pressure that kind of send things in.
And it's probably not going to be effective at these super high flow rates anyway. 40 liters per minute is rocking. So your little bit of tape's not going to do anything to cover that. Anything else?
Couple comments. one of the things that I found helpful when suturing these, and currently we like a lot of times have like very like one-on-one DVM involvement with these cases, just because transitioning them from their nasal, like regular nasal flow or from the O2 kennel to their high flow is often like a period of kind of sometimes crisis, depending on how much sedation the pet is needing. But so sometimes as I'm like starting up and getting the machine warmed up and getting it running, I'll put a little bit of a lidocaine cream, like right where my initial sutures are gonna be, and I'm not sure much of that.
No, I did not. That's a good tip.
So put it right here. I don't commonly use it back here. I feel like they're a little less sensitive for that. And also I'm like right by the eyes, but a little lidocaine cream right here. And then right before I go to start placing them, I kind of just wipe it off with a little bit of gauze because it's gonna get on your gloves and get on everything. So wiping it off because I feel like a lot of times after being those nasal cannulas in, we're holding them in place temporarily while the pet hopefully then settles and gets used to it, and then we're suturing kind of on either side to start, and then getting them more stabilized, and then kind of adding our other attachment points. The other point that she had kind of mentioned on was like getting the machine warmed up and getting it going before doing your patient transition for your cannulas. And I also think that's important because sometimes on the machine, depending on either its feelings for the day or like how you load the cartridge, if you loaded it correctly or not, or, you know, sometimes I've done it, like, I don't know why, but now I can't adjust down from 100% oxygen. Like sometimes we have a patient all set up and the knob is just like beeping at me when I try and tell it to go down 100%. That's rare, but I always make sure before I'm like starting that transition process for the patient that I'm able to adjust all 3 values on my machine. And I don't have any issues because once I get that patient out, once I get their cannulas in place, I want to just plug them into the machine. So
Would that be with that happens? Turn on.
So sometimes, yes, I turn off, turn back on. That's the most resets. But then other times I've actually had to switch out and get a completely new cartridge. Sometimes I feel like there's some cartridge issue or a loading issue. In theory, it's a pretty straightforward, simple machine. But I do feel like sometimes we hit these hurdles where we're like, I don't have a good way of explaining why this happened now versus the last 7 times I did this. So that's it.
Awesome. And we'll, like I said, go through HiFlow in a lot of depth. So everybody should feel comfortable changing those settings to your point, Bridget.
Sorry,
No, please go.
what is like the max time that they can do it?
100%, I usually like to keep that below 8 hours. Yep. If I can get them below 80 within 8 hours, I'm pretty happy, and below 60 within 12 or 18 hours. There's no like set timeline, like, oh, at 7 hours and 30 minutes, you don't have oxygen toxicity, and at 8 hours you do. So we're really just being conscious of like those rough timelines and as aggressively as we can without doing harm to our patient, bringing those oxygen levels down. Below 60, I'm happy. I could keep them at 60 for days. Anything else? Okay, why don't we take a short break before we go into ventilation, because that one's gonna be a big one.
Okay.
So go to the bathroom, get food, whatever you want, and we'll be back here in 5 minutes.
Good, how are you?
It's not gonna be that really similar.
And again, it's not like, you might get a PT 2 days after it's too long. Is that right? Process, or is that? Toxicity is hard to see. Like it's really hard to So that's a tricky one. Really gonna be like science. I'm gonna see increased consolidation. Well, unless you're, I mean, it's gonna be with high flow because they are reading a mixture in there. Yeah. 100%, so it's got a little bit more. Definitely if it's much more the big issue of the there. Or if like you're stuck in this session, for whatever reason, and they're getting percent. So while it is an important consideration, ultimately, like if my patient needs that more aggressive therapy, they need it, right? You know, I'm not gonna ask them to be for a quad period of time because you don't want it in the future. Yeah, it's like that. So, you know, a good example is like in the down and dirty. In a practice that didn't have a ventilator, but also they're sitting ventilator for 16 hours. Definitely, I'm just after we have doctor. Pretty sure it's really too long. We got the question. It would have died. Davis. So. Yeah. Well, and most of the time, again, it's doing this really like wild. We have starting, but it's gonna go here. Right, you're gonna be more slower. We, you know, a longer to kind of analysis that I've heard of whatever it is. It's not usually something that we not say, and it's not usually something that's. That's over about it. That's well. Yeah.
Can I show you this?
I'll scroll like it's on the top. Overland. Yeah. Oh my God, don't tempt me. I'll be like, oh, it's time. No.
Yeah.
Oh my God. Attached to this little style or style.
From it, like on the like they're actually like really sick.
I think it works. There's also ask for it. Better. Yeah.
In a yard. No, it's like.
right. Get started. We have a big subject to get through. Okay, so mechanical ventilation. This is probably why I've been in the profession as long as I have. It's the only thing I love to do. That's not true. It's the thing I love the most to do. But they're a beast. And they take a lot of practice and dedication to learn. So as I mentioned earlier, I'm going to give you guys an overview, and we're going to spend the bulk of our time having a discussion about nursing care. But again, this isn't about me, this is about you. So if you want to take the conversation elsewhere, let's take it elsewhere. We want to make sure that you're getting what you need out of this. I am just going to provide you with, I think, what the most important information you'd need to know if you're going from zero to vent, because it's on your shift and you have to, what you should be thinking about. So before I get into it, why is this machine so special? We're going to compare it to an anesthetic ventilator, which might be a ventilator more of you are comfortable with than with this big guy. Just like HiFlow, we can titrate our oxygen with this ventilator, and we can provide humidified air, which is going to decrease the amount of irritation we cause those airways, either by oxygen toxicity or by forced dry air. We also get to set a lot of parameters and control a lot of different aspects about the breath we deliver, which becomes really, really important when we're ventilating patients that have diseased lungs versus ventilating them for other reasons, like intracranial disease, for example. In addition to being able to set all of those highly specialized parameters, we get a lot of information about that patient's pulmonary dynamics from our ventilator as well. So we'll see as we get into this, there are all sorts of confusing graphs and charts that give us lots of really good information about what our patient's lungs are doing. So actually, funnily enough, in my experience, when a patient's on the ventilator, I feel really happy because I can see everything that's going on, know exactly what's happening. It's transitioning off the ventilator, even though they're probably healthier than when they were on the ventilator. That is scary. Like, where is my volume pressure loop? I don't know what's happening. So if you can learn to kind of read that, it's actually a really, really nice modality to fully understand what's going on with your patient. So that's why they're so special. And there's really not a good substitute if you need a ventilator. So we talked about how HiFlow can be an intermediary step. It's only in really specific circumstances. And we'll talk about it more, but if you need a ventilator, you need a ventilator, and HiFlow is not really going to help you. But before I get into more specific, I do want to spend a brief time just talking about prognosis. In my experience, when I'm teaching the ventilator, the general vibe from everybody is that everything that goes on a ventilator dies. Why bother? They're all going to die anyway. It's not true. It's not the best survival rate, but it's also not the worst. It's really heavily determined by the disease process. So we have really good outcomes with central nervous system disease, cervical spine compression, so post-op ventral slats, congestive heart failures, they come off the vent pretty easy, aspiration pneumonia, hypoventilation, and intoxications. So obviously it depends on what the prognosis of that underlying disease process is as well, but we can usually get them on the vent if they can survive whatever CNS disease they're suffering from, for example. We do have worse outcomes with patients who are on the vent after cardiopulmonary arrest, as you might expect. Intracranial disease, again, doesn't carry a good prognosis on its own, but those guys can be difficult to get off the vent. And ARDS tends to carry the worst prognosis. Veterinary medicine, we're looking about 8% patients coming off the ventilator who have been in acute respiratory distress syndrome. So overall, in this study here, which was done in 2022 as a follow-up to a 2001 study from Kate Hopper and her crew, showed about a 22% success rate overall. So just really heavily simplifying this analysis, overall, 22% of those patients came off the ventilator. Yeah, we take longer shots almost every day in our hospitals, right? That's 1 in 4. It's not great. I'm not going to lie to you, it's not perfect, but we've taken longer shots a lot, right? And we believe in those shots when we're taking them. So we should believe in this one too. So, which kind of brings me to my soliloquy for the day, having ventilated a lot, I'll be honest, 22% sounds terrible. But in my experience, just like anything, the more committed you are, the more you learn about a modality or a skill, and the more you practice it, better you are at it and the better your outcomes are. Like how many of us learned something really difficult and had 10% success rates to start, 20%, 0% maybe? So by treating these patients as if they are going to survive, because 1 in 4 is still a pretty good shot. And by learning the ventilator and really committing yourself to it when you have patients on the ventilator, I think we improve our outcomes. So I have no scientific backing behind this whatsoever. So massive caveat with what I'm about to say. But I was lucky enough to practice at a place in San Francisco where we had patients on a ventilator more often than we didn't. So we ventilated between 6 and 10 patients a month. And our success rates there, just anecdotally, I didn't write a study, didn't do an analysis, but anecdotally, they felt closer to the human medicine survival rates, where somewhere between 50 and 70%. With ours a little lower, but good survival rates. And again, I think it comes down to that practice and that commitment. So if you're ventilating once a year, it's going to be uncomfortable when you're doing it. But again, by doing the best we can for our patients and learning about the ventilator when you know you're going to be working with a patient on it, like it's coming up, your shift is starting, or you know, tomorrow, because they put it on the vent last night, I'm going to have to deal with it. I think really learning this modality can help our outcomes quite a bit. Again, totally unscientific, but we ventilate it all the time, and you end up being good at what you're comfortable with, right? So I want to get just a couple, a very brief talk about some couple concepts that we should, throughout the rest of this talk, kind of be coming back to regularly. And the first is oxygenation versus ventilation. So these are interdependent processes, but they're distinct from one another. And I think they can be conflated in our everyday nomenclature. And it's going to be a very important determining factor as to whether or not a patient needs high flow or needs a ventilator. So oxygenation is going to be the process of oxygen transport, oxygenating our tissues, supplying the body with oxygen. So this is going to occur when oxygen diffuses into the blood, attaches itself to that hemoglobin, and gets transported to the tissues. This is going to be measured by the pressure of oxygen in the blood, so a partial pressure through our gases. Whereas ventilation over here, this is going to be the exchange of gases in the lungs. So yes, they are interdependent. We need that exchange of gases in order to get oxygen into that bloodstream. But ventilation is going to occur through respiration, breathing in and breathing out. And what ventilation is going to be measured by is the partial pressure of carbon dioxide in the blood. So how well are we actually getting carbon dioxide out of the body? It's going to measure how well that gas exchange is occurring in the lungs. So when we have patients that have a primary oxygenation issue, high flow might be a good modality for them, right? If we have a ventilation issue, we need a ventilator. That's the name. High flow is not going to ventilate for us. We talked about that CO2 washout. That's the only time where there might be a little bit of middle ground, but ultimately the ventilator is not going to actually ventilate. Then we have a concept called ventilation perfusion mismatch. Not going to go too in depth into this, but I'm going to be talking about this briefly. So I wanted to just give you a little bit of an overview. So ventilation perfusion mismatch occurs when the air that's going into the lungs doesn't meet the blood that's going into the lungs for whatever reason. So we've talked about air going into the lungs as ventilation. We need blood coming into the lungs in order for those gases to exchange, right? Oxygen can't hop onto the bloodstream if the bloodstream's not there, and CO2 can't hop out of the bloodstream if the bloodstream's not going to where the gases are. So we've got a couple different types of ventilation perfusion mismatch. Very simply, we have ventilation perfusion mismatch where we have alveoli, so those functional units in the lung that have no gas in them, or something's blocking the gas from getting to the bloodstream, but we have normal perfusion. So I've got blood going through the lungs, but I don't have gas going to the blood. And then we have wasted ventilation or dead space ventilation, where we've got good air going to the lungs, but we don't have any bloodstream to actually get that gas exchange going, even if we have air in the lungs. So this could be an example of a pulmonary thromboembolism. There's a big old clot in those lungs and blood can't get around that clot. So those lungs are capable of gas exchange. We don't have any blood to actually provide that gas exchange. And shunt perfusion could be like ARDS. We've got a bunch of fluid in those lungs or pneumonia, and there can't be gas exchange through those fluids. So we've got that blood flow, but we don't have that gas exchange. So when I talk about ventilation perfusion mismatch, this is the concept that I'm referring to. Your ventilator is going to be able to help with that in a lot of cases, whereas your HiFlow is not. Okay, indications for ventilation. Again, we're going to talk about this very broadly, but the first and most obvious one is going to be really severe hypoxemia. We also have severe hypoventilation, increased ventilatory demands, which we'll talk about, and failure to respond to HiFlow. So just like if we're putting a patient on HiFlow, they failed to respond to traditional oxygen therapy. If they fail to respond to HiFlow, we need our bigger guns. So looking at this in a little bit more detail, I do want to start with HiFlow. So we can provide that higher fraction of inspired oxygen with mechanical ventilation. Again, both of them can get up to 100%, but the ventilator is a closed circuit. They're getting that full 100%, whereas HiFlow, we have an admixture of just normal ambient air. So 70 to 80% is more reasonably the highest we can achieve with HiFlow. And we can get a lot more aggressive support and specialized support depending on their pulmonary dynamics through the ventilator itself. So the rule of thumb is that patients who don't improve or continue to worsen after 30 minutes of HiFlow should be considered candidates for mechanical ventilation. That does not mean they immediately go on the ventilator, right? It means we have conversations with owners, we have our critic list weigh in. But these are the patients that as technicians, I want you guys to keep an eye on. It is important for us when we put a patient on HiFlow to not only just write our numbers down in SmartFlow and make sure our patient's comfortable and have all of our supplies and our settings and all of that, but we need to be in contact with our doctors as to whether or not those patients are improving, staying the same, or getting worse. And staying the same is still a problem. Staying the same is still an indication for mechanical ventilation, technically. So making sure that we have that timeline in our head and we're paying attention to that, along with the million other things that we have to do, will be very, very important here. All right, and then we have severe hypoxemia. So this is going to be an indication for ventilation if a patient has really persistent severe hypoxemia despite oxygen therapy. So they come in with low oxygen levels and they respond to oxygen, great. We don't need a ventilator. But if they fail to respond to oxygen or to HiFlow, they would be a good candidate. This is going to be defined as a PaO2, so that's our blood gas value, the partial pressure of oxygen in the arterial blood, less than 60 millimeters of mercury. Again, we're not really poking a bunch of patients who can't breathe for ART gases when they present in the ER. So that's going to correlate with a pulse ox of about 90%. If you can't get those numbers, that's fine, because we're looking at our patient's clinical state. They're not numbers, they're animals. So a prolonged increased work of breathing may result in respiratory muscle fatigue, and so that's really what we're going to be looking for. Now, I have this lovely graph up here, and I promise I'm not going to make anybody do any math today, but this is called the oxyhemoglobin dissociation curve. And this shows the relationship between that partial pressure of oxygen, or kind of total oxygen levels in the blood, which is shown down here, and what our SpO2 gives us, which is hemoglobin saturation. So the reason I bring this up is because we're talking about this 90% number correlating with this 60% number. So we think 90%, and not all of us think like, oh my gosh, that's super severe hypoxemia. But it does correlate with really, really low total oxygen levels here. And you can see that it's right at the start of the super precipitous drop off, where as our pulse ox continues to decrease, the partial pressure of oxygen in the blood decreases even more. So again, we're not going to really go into this. I love it, but I won't bore you with it. But this is important to remember, that 90% number, while we're in the 90s and we might think that's awesome, it's could be awesome if you're in the 70s before, but it's the start of this really precipitous drop off, and it is considered severe hypoxemia. All right, our next indication is going to be severe hypoventilation. A lot of different things can cause hypoventilation, and we're not going to spend too much time on specific disease processes, but your big candidates for this are going to be central nervous system disease, cervical spine inflammation. So again, those post-op C-spine patients, paralysis, and VQ mismatch can all do this. We can also see severe hypoventilation as a result of respiratory muscle fatigue, the end stages of hypoxemia, when that patient is just exhausted and can't breathe anymore. So hypoventilation is going to be determined by assessing a patient's CO2 levels. So when a patient is hypercapnic, we can consider them to be hypoventilating. So that's going to be a partial pressure of carbon dioxide in the blood, or a PCO2 greater than 50. And our hypoventilation can also cause hypoxemia. Again, we talked about how oxygenation and ventilation are interdependent. They are distinct, but they're interdependent. We do worry about hypoventilation causing hypoxemia as well. So this is going to be, all of those disease processes that I stated earlier are typically going to result in a severely reduced tidal volume. So the amount of, like, the quantity of air that a patient is going to breathe with each breath, and or respiratory rate. So really, really slow respiratory rate, even if they're breathing a normal amount with each breath. Oftentimes we see both of those. That can very quickly progress to apnea and death, especially if their CO2 is getting very, very high into the 80s, 90s, 100s.
Is there a relationship between the PCO2 and end tidal CO2?
Yes. We'll talk about that a little bit when we talk about capnography, but absolutely. A number of factors can affect it, but end tidal CO2 is essentially going to estimate our arterial levels of carbon dioxide. Good question. So our next indication is going to be increased ventilatory demands. And this is going to be maybe one of the least frequent reasons why we might ventilate a patient, though we still do it sometimes. So this could be that dead space ventilation we talked about. So that pulmonary thromboembolism, where we've got a big portion of the lung that's not getting blood flow, and therefore the rest of the lung is going to have to do a lot more ventilation than that one. So we might put patients on a ventilator for PTE. But severe circulatory shock is another reason that we might put a patient on a ventilator. So this could be your sepsis cases. This happens far more often in the human world. So we have information on the outcomes from the human world. And it's less, I've seen it probably twice in my career, but it's certainly done sometimes. And in cases like sepsis or really severe circulatory shock, we do a couple things by providing ventilation. So we can increase the amount of global oxygen delivery to tissues that are using a lot of oxygen or don't have access to a lot of oxygen. And we can reduce how much oxygen those respiratory muscles are consuming, which in some cases can be up to 20% of cardiac output. So a really, really significant amount of the oxygen that circulates through the body, especially in our critical patients, is used by the respiratory muscles. So if we can eliminate that respiratory muscle need and support their oxygenation a little bit, we can give them better outcomes, or at least we know that we do in the human world. Any questions on that? Okay. So I want to talk about some of the ventilation modes that we have, and then we're going to get into startup. So this is really just going to be a broad overview and some very brief definitions on what we're actually controlling with this ventilator. So when you go to start this up, you know what you're looking at and you know what you're manipulating. So the first type of variable that I want to talk about are going to be our control variables. Sounds very much like technical speak, like pilots or something in my mind. But really, this is just going to be the setting that we manipulate to control the breath. It's not going to be as complicated as some might make it out in their head. So this could be pressure, this could be volume, this could be flow, or this could be time. So depending on the type of anesthetic ventilators you're used to, if you've got a ventilator with those big bellows that go up and down, That's a volume. We're delivering a volume. If you have the ventilators where you can set like PIP and PEEP, that's a pressure controlled ventilator. And most MRI safe ventilators where you're setting inspiratory and expiratory time are time or flow ventilators. So you've probably had some sort of contact with every type of ventilator that we're talking about here. But to just narrow it down to the two that I think are going to be the most important, it's going to be pressure and volume. Those are going to be the main control settings on this ventilator. So when we talk about pressure control, the ventilator is going to deliver a breath to a preset pressure. So the setting that we are determining for that breath is going to be pressure based. This is going to be used primarily for patients with pulmonary pathology. There's a lot of flexibility with that, but usually we're going to start our diseased lungs in a pressure control. And that's because it's thought to be safer, as it's still going to allow the amount of tidal volume or the amount of air going into the lungs that we want without having to make arbitrary decisions about that volume. Think of our patients and their varying anatomies and their varying sizes. Tidal volume is already, like, I can't look at any of you and determine what your tidal volume is. It's going to be different even if you're the same weight. It's true of our patients. Those really skinny, big chested dogs, like greyhounds, for example, they're going to have massive tidal volumes compared to their weight. Whereas your Frenchies or your English bulldogs are going to have teeny tidal volumes compared to their weight. So if we can set a safe pressure and then from that determine what their tidal volume needs to be, we theoretically have a safer ventilation. With all that being said, we do need to make sure that we're monitoring tidal volume, however. We have to make sure that these patients are still going to receive an adequate amount of breath. We'll establish that usually within the first few hours that we put a patient in pressure control. And then that's going to be alarms, alarm settings that your criticalist can set to alert you to when that tidal volume has either gotten too high or too low and there's a problem based on what that patient has told us is their normal. This is usually what I'm electing to ventilate my patients in, is a pressure controlled mode. But we also have volume control. So this is where the ventilator is going to deliver a breath to a preset volume. So instead of setting a pressure, we're setting a volume. And within reason, the ventilator is saying, I'm just going to let whatever pressure needs to occur to get that volume into the patient. So this is going to be more frequently used in patients with healthy lungs. There's absolutely nothing wrong with ventilating healthy lungs in pressure control, but some will find it easier in volume control. So this could be your central nervous system disease kiddos, your cervical disease kiddos, excuse me, or your paralysis guys. Now we have a couple more complicated and fancy ventilator modes that are worth touching on because you're likely going to be ventilating in them at some point or another. And these can be, well, SIMB at least can be either pressure or volume controlled. So you can operate this mode in either. So this is going to be synchronized intermittent mandatory ventilation, SIMB for short. And like I mentioned, this can be used in pressure or volume control. So regardless of what our patient wants, we can use SIMB. Now, what is special about SIMB and why we use it frequently is because we can set a number of mandatory breaths and we can tell that ventilator, no matter what, I need my patient to receive this amount of breath over a minute. And the patient is still allowed to breathe in between those breaths. So for patients who are, excuse me, starting to get their respiratory drive back or starting to wean them off, we can allow them to start breathing. And the ventilator is going to work to synchronize the spontaneous breaths that the patient takes with the ventilator delivered breaths so they're not fighting each other. So this is a really, really nice mode when you've had a patient on a ventilator for a while and you're starting to ask them to do a little bit of work. So it's nice and safe for the most part. It's not going to cause the problems that you get when a patient starts fighting the ventilator. And as I mentioned, it's synchronizing those breaths as best as it can. It's not absolutely perfect, but it's synchronizing those breaths to make sure that it's still delivering what you've asked it to do, but that patient can freely breathe against the ventilator. The next mode is a bit newer, and a lot of people are pretty excited about it. Your ventilator is capable of this mode. It's called pressure regulated volume control. So this is an adaptive targeting ventilator mode, which basically just means that these smart ventilators are going to analyze every breath it gives and deliver the next breath based on what it learned from the patient in the previous breath. So it's attempting to create sort of the best of both worlds with pressure control and volume control. So it's analyzing those pulmonary dynamics breath by breath to continuously make adjustments. So it's going to meet a tidal volume target, but it's going to give the breath in such a way that the lowest possible pressure is delivered to a patient. Higher pressures are going to cause more damage to the lungs, and it's really important that we avoid them. A lot of patients need higher pressures while they're being ventilated. So this mode theoretically allows us to meet our tidal volume targets without having to set an arbitrary pressure to achieve those. It's often, for that reason, used as the initial mode of ventilation in ICUs. It also has sort of a set it and forget it, both benefit and detriment, in my opinion, to it. Because you can just set it to the tidal volume that you need, and the ventilator is going to make all of those other changes that we would typically be doing based on what those pulmonary dynamics are. However, I am always skeptical of those set it and forget it modes. Psychologically, as the people caring for them, I need us paying attention to that ventilator. So if you are venting in this mode and you're not making a lot of changes to that ventilation, make sure you're still watching your patient and their values. But patients can also become maladaptive to this. So because this is adaptive targeting, patients can sometimes, especially after a couple of days in PRVC, at least in the human world, I don't know that I've seen a veterinary study on maladaptation to PRVC, but it happens in the human world where it stops working for them essentially, and they start bucking the ventilator. So it's really nice when you need it, but it's probably not going to be the end all be all that some people tend to think it is. And your ventilator can do it, and you will likely see it. Any questions on that? I'm starting to lose my voice. I apologize for the coughing. So I do want to define very briefly a couple different types of breath types that the ventilator can deliver. So this is going to determine how the breath is initiated or how the breath is terminated by that ventilator. So we have a controlled breath, and that means the ventilator's doing all the work. The ventilator's starting the breath, the ventilator's finishing the breath based on what you've told the ventilator to do. We have spontaneous breaths. This is where the patient's doing the work. The patient's starting the breath, patient's ending the breath. And then we have supported breaths. So this is something you'll see in PRVC. This is also something you're going to see in SIMV, where the patient can start a breath, but then the ventilator can augment that breath and finish it off the way you've preset it. So when we're running in a supported mode, we have two sets of settings essentially. When we want the ventilator to deliver that mandatory breath and what type of breath we should deliver when the patient wants to breathe on their own. Usually they're going to be exactly the same until we start the weaning process. But you are going to see an extra set of settings if we're working in a mode like SIMV, because we can have the ventilator give a totally different breath than the breath that a patient triggers. I have left this here more or less for your reference because I'll be sending this presentation to Brooke. These are going to be a good portion of the settings that we can manipulate on our ventilator, and a brief description of what they mean. Obviously, this is not going to be a comprehensive description by any means, but it's a good start. Just a couple things that I wanted to touch on. So frequency is going to be our respiratory rate, our preset respiratory rate when we're talking about a ventilator. So you're not going to see respiratory rate, you're going to see a little F for frequency. And then PEEP is what we talked about, that positive end expiratory pressure. So on a ventilator in a closed circuit, this is something that we're going to be able to manipulate and control. We want to know what our P peak is, or sometimes called PIP, peak inspiratory pressure. So this is going to be the pressure in the airway at its highest. This is going to be something that we're going to have to monitor. This is something that we're going to be writing in Smartsheet to make sure that we're staying at safe pressures. Same with our tidal volume. So VTE is our tidal volume. We want to make sure that we are keeping our tidal volume within safe ranges. Those ranges are going to be patient specific and typically set by your critic list. So just to give you a very brief rundown of some of the more important settings here. But of course, you could do a deep dive into any one of these things, and I strongly encourage it. It's just not going to be in the cards for today. All right, any questions before we go into setup? Okay. We're done with definitions, so at least there's that. Pretty sure. Okay, so to start out, your ventilator is a servo U ventilator. These are a newer model of ventilator. They're really, really nice. So I just kind of wanted to introduce it to you. We're going to go through the startup and we're going to talk about some of the settings that we can manipulate and what needs to happen when we're putting a patient on a ventilator before we do it for real with this guy. What's really nice about this ventilator is, you know, the human world, they study everything. Safety is primary and they have to prove it. They've studied this ventilator and it basically, of all the other ventilators that are commonly available on the market, was the easiest to use, the safest. So you guys got a good one. I do really like ventilating with these guys. So it's all to say, don't be too intimidated by it. I'm going to show you how this can make your life so much easier than having to memorize a bunch of things like on the stupider ventilators from decades past. So when we are initiating the ventilator, obviously we're going to plug it in. We're going to connect it to a wall outlet and not a power strip. Very important for your ventilator. We also want to make sure it's connected to oxygen. And then we're going to locate and open the hatch. So this is going to contain your, and I'll just show you, it's going to contain your on button. So there is no front or back to this ventilator. You can have it however you need it. That hatch is going to contain connection points and your on toggle right here.
Toggle does like to hide.
Yes, on every ventilator. Bearing in mind that most of these are designed, well, all of them are designed for human use, and nobody wants it to be very easy for a family to switch that ventilator off. So to turn it on, you're going to flip that little toggle. You do have to pull it down and move it over, but you can see it right there. And then when your machine starts, it's going to ask you to do a pre-use check. We have to do this for every single patient that goes on the ventilator. So you are going to get a prompt for this as soon as it starts up, and you're going to hit yes. Again, every single patient that goes on the ventilator needs this pre-use check. You don't have to run it multiple times for the same patient unless you have a problem with your ventilator. You do have to run it in between patients. And what's really nice about this guy is we have illustrations that are going to show you exactly what you need to do, and it's going to tell you exactly what you need to do. And you're going to go through all of these steps. The final step is going to be your patient circuit step. This can be a separate test, or it can be part of your pre-use check. So we can test patient circuits whenever we change a circuit without having to go through this whole pre-use check. But it's going to be a part of the initial test. That being said, it's really important to use the exact circuit you intend to use on the patient when you're doing this circuit check. And if you're using a humidifier, make sure that the humidifier is turned off and you have the chamber filled with water. So this is going to be testing, not only pressure checking your circuit and making sure that your circuit can actually tolerate what the ventilator needs to do because it's sealed and it's closed, but it's going to be testing the compliance of your circuit. So everything's going to be a little bit stretchy when it's under pressure, right? The ventilator is going to measure that so it can better provide you with patient information that's not kind of lost in the noise of circuit compliance. You definitely have to use the circuit you intend to use for your patient. And if you ever change the circuit for whatever reason, you have to do another circuit test. So once you've done that and you've passed that, you're going to see the standby screen. And this is where you're going to sort of select your patient type and all your ventilator types and settings. So you're going to select your patient size. For the most part, we're going to be venting in pediatric or adult, not often neonate. You can see the tidal volume here. So these ventilators aren't going to tell you by weight. They're going to tell you by tidal volume. 100 correlates with maybe a 20 kg patient max at lower tidal volumes. So most of your patients are going to be adult or peds. Oops. Your ventilation type is going to be invasive. So these have a non-invasive ventilation setting. That's going to be sealed masks. We see that a lot in the human world. Really hard to get a seal on a muzzle, so we don't really do that often in veterinary medicine. So you're always going to be selecting invasive. And then your ventilation mode is going to be determined by your criticalist. In an emergency, pick pressure control. It's going to be the simplest and it's going to be the safest, and it's going to get your patient on that ventilator if you're okay with that recommendation. Okay. We don't need STIM-V when we start patients on a ventilator. Yes, I said ICU start patients in PRVC, but it's a bit more complicated. And I'm all about just like getting the patient on the ventilator when they need it, as opposed to making sure everything's absolutely perfect. We have time for perfection once they're stabilized. So some helpful information to know about this ventilator is, so this is the screen you're going to see when you go to select your ventilation mode. If you press and hold this button, it's going to tell you all about that ventilation mode. If you forget anything I've said, if you don't have a resource in front of you, this is a massive resource. So when you're playing around with the ventilator today, it's in a couple weeks, and you're like, oh man, I forgot that, I want to remember that. You can turn it on, you can set it up, and you can learn all about the types of ventilation modes that your ventilator can do. We have scratched the surface. As you can see, we have a lot of different options here. It's a pretty nice ventilator that you guys have. And then we're going to set our initial settings. So once we've selected our mode, that's going to determine what type of settings we can set. And all of the available settings are going to be displayed on the screen for you. So to change, you're going to press the setting, and you're going to have a little screen that allows you to adjust to where you need it to be. And then you're going to hit a check mark that's going to save that setting for you, and you can move on. Once you have all of your settings set, you're going to hit start ventilation, and it's going to start ventilating for your patient. So I do have some information on what your safe start settings would be based on whether or not you're venting diseased lungs or healthy lungs. These are all pulled from Kate Hopper's very wonderful overview of mechanical ventilation. So these are not going to be necessarily specific to your ventilator. I'm going to work with Brooke and Bridget and give you guys a nice kizzy guide. But it's a good place to start if it's like a down and dirty emergency, your criticalist is an hour away, you got to get something on the ventilator. You can start them safely here. So we're not going to go in detail here, but it's here for your reference. These would be the settings for normal lungs, which are going to be a little bit more aggressive in terms of tidal volume than your diseased lungs. And once you have those settings, you're going to see a screen like this. So this is going to be our main operating screen on the ventilator. And while I'm not going to go into crazy detail about all of this, I did kind of want to give you a bit of an orientation as to what we're looking at here. So over here, we have our measured parameters. So these are not parameters that we set. This is information the ventilator is telling you about your patient. So these are going to be things that are going to have to be recorded on Smartsheet at least every hour or when we have significant changes, because this is telling us what our patient is doing and how effective our ventilation is.
She means SmartFlow, by the way.
Oh, yeah.
Smartsheet is burned
Thanks,
to our
Brooke.
brains. Just in case you were confused.
And then we have our settings down here. So these are the settings that we can change. Oh, no. So these are the things that we do change when we are initiating ventilation or adjusting ventilation. And this is our menu here. If we ever need to go into standby, like we're taking a patient off a ventilator for whatever reason, whether it's temporary or not, we have modes of ventilation, so we can change the mode of ventilation while a patient is actively being ventilated. We have alarm limits, which are going to be set by your criticalist based on each patient. It's a really nice function because they're going to tell you when they want you to notify somebody. You don't have to guess. We have maneuvers and views, lots of different things that we can look at. But what I want to call your attention to are a couple different things. So the first is going to be suction. And then we have our O2 boost here. And we have all of these little green arrows. So we'll go into suction and O2 boost subsequently, but these green arrows, if you click on them, are going to expand your settings and you're going to see everything. Then we have this center where we can show our loops and scalars. Again, we're not really going to go into loops and scalars today. That's definitely beyond the scope of this talk, but this is all going to give you additional information about the type of breath that that patient's receiving. One thing that we do have to do after we set our initial settings is we have to add in the body weight by hitting this VT PBW button here. So this stands for predictive body weight. So essentially this is going to allow us to display our tidal volume in mils per kg, which is how we're going to think about tidal volume. So instead of just giving you a number, it's going to tell you how many mils per kg that tidal volume is. It's really helpful information for your criticalists when they're making decisions. All right, and to get into alarms, we have 3 different alarm urgencies. We have red, yellow, and blue, with red being the most urgent and blue being the least. Your ventilator lights up, it yells at you, and you get a bunch of blinking things on your screen when you have an alarm going. I'm not going to talk about what the alarms are and how to troubleshoot them because your ventilator will do it for you. You have an alarm, you click on this, it's going to open up a screen and it's going to tell you what that alarm is, why it's happening, and what you can do to fix it. Additionally, back on that settings screen, whatever parameter is causing the alarm is going to blink you. Make it really, really, really easy. And I would encourage you as we play with this ventilator today to try to get it to alarm so you can troubleshoot the alarm. I have a couple ways of doing that so we can get it to an alarm and you can see how it walks you through it, but it's incredibly, incredibly smart. Okay, so as promised, some specific functionalities that I think are going to be important for you guys to be aware of. First one is the O2 boost. So this button is going to give you 60 seconds of increased oxygen support. We can set this to whatever we want it to be, but I usually keep mine at 100%. So I am going to use this if I'm disconnecting my patient for some reason. Maybe I have to go grab a weight. Maybe I'm going to take chest radiographs for the day. Or maybe it's an emergency. My patient's suddenly not doing well and I don't know what it is. Don't know why it's happening. I will hit that O2 boost button. I get 60 seconds of 100% oxygen without having to think about anything or go through a bunch of settings to change it. So really, really nice one to have, you know, before you suction, etc., to make sure that your patient's just a little bit extra saturated before you stress them out, or if your patient's in trouble, you can support their oxygenation while you try to figure out what is going on. So I really, really like this O2 boost button, and it has a countdown timer. If you need more time, you just hit it again. And then we have our disconnection button, or disconnection/suction. So this is going to allow us 60 seconds of disconnection where it's not going to actively ventilate. So you hit this button and you disconnect your patient. It's not going to scream at you, which is nice. But additionally, it's going to have a countdown timer. So you know when 60 seconds of disconnection has passed and you can start thinking about connecting your patient again. And then when you do connect them, it's going to give an increased FiO2 for that patient for another 60 seconds, which again, we can set, but I usually have it 100%. So if I'm going to suction the endotracheal tube, which we'll talk about, I have my 60-second timer. And when I reconnect that patient and the ventilator starts ventilating again, I get that extra oxygen boost. So my patient's not trying to catch up, give them a little extra support. Then we have our patient trigger indicator. So this is not a setting, but this is something we're looking out for. So this is going to tell you when a patient's taking a spontaneous breath versus a controlled breath. So it's this little lung symbol that's going to flash on the screen when your patient breathes. And it just means that your patient's taking a breath on its own. You're going to see that in those loops and scalars, those big graphs too. It's a different color when a patient triggers their own breath. But we're going to want to keep an eye on that because that's very important information for us to have when we start weaning patients. Are they triggering their own breaths or not? And then finally, we have the record function. So we can press the camera button here, take a screenshot of the screen. We can press the little camcorder, the recording button here, And it's going to take a recording starting 15 seconds from before you pushed it to 15 seconds after. And it's going to record all the waveforms, all the settings, everything. And then to access those recordings or screenshots, you're going to hit this media button and it's going to store up to 40. So if something crazy is happening and you don't have time to grab your phone and like open up your camera app, you can grab everything on this ventilator itself. You can export these. It's like a USB stick. It's a process. So if I were sending something to my critic list and it's like, I don't know what I'm looking at, I would use my camera. But if it's an emergency or you need to catch something quickly, this is a really good option. All right, and then we have stopping ventilation. So how do we stop ventilation? Whether we're moving a patient or they're transitioning off the ventilator, we need to make sure we're stopping the ventilation in the right way. So you're gonna hit this standby button to force the machine into standby, but you're also gonna have to press and hold that stop ventilation button for 2 seconds. So that's an important one that it doesn't necessarily tell you on this screen. I believe for safety reasons with patient visitors in the human world. So you're gonna have to press and hold that stop ventilation button for that full 2 seconds. And then it's gonna put you back into that standby mode that you started in. You can start ventilation from that standby mode with all the exact same settings you stopped ventilation in. So if you are disconnecting a patient for a long period of time, I don't know, maybe they're going to get an MRI or something like that, and they're gonna be on an anesthetic ventilator for a while, it can go into standby, it can hang out plugged in, connected to oxygen, no problem. And when you put that patient back on the ventilator and hit start ventilation again, it's all of those settings that that patient was on before. All right, any questions on that? Yeah.
I'll just make a comment that if you're worried about your patient and your DVM is on the phone or in the next room or going to the bathroom or something like that, you can always hit the screen record button and like take your 30-second video and then hit your O2 boost usually. And that can buy your patient and you a little bit of time to like get what you need to get done. And then, for example, if they're reaching out, think the overnight DVMs reaching out to the critic list about a concern or troubleshooting, a lot of times, like we'll just get like a video of that 30-second screenshot. Like someone will like video that screenshot when they go back to replay it. So the corners are your friends.
Definitely.
Is there ever going to be a time where hitting the O2 button is going to be like something that you can get upset about? The O2 boost button.
Before an art gas.
Yeah.
That
I
would
would
be
say like if we're trying to obtain measurements of what the patient's been doing and like a historical measurement of how successful we're implementing them, then sure. But if they're in a crisis, I guess.
So monitoring parameters. I'm not going to go through everything. You're going to monitor these guys with all the diligence and all the parameters of an anesthesia. So you're going to have everything set up on them. I'm, again, not going to go through every single one of those, but I'm going to talk about some of the big ones in the specific context of ventilation. This is not going to be like a really comprehensive overview, but we will chat about it. And we'll start with the fairly obvious one of capnography. So this is going to be absolutely essential for guiding your ventilator therapy. Brooke's question earlier about whether end-tidal CO2 correlates to arterial levels of CO2. Short answer is yes. The long answer is we use both of these values in conjunction with each other to determine a lot about what's going on inside of our patient. So we want both of those. Capnography is incredibly important. So as a reminder of kind of the journey of gases throughout the body, we have inhalation, where we then have gas exchange that enters pulmonary circulation, systemic circulation, capillary beds, and into cells. So that's where oxygen's going. And we have a process called cellular respiration, where energy is generated in cells that produces CO2. From there, it takes the opposite journey of oxygen, enters those capillary beds, systemic circulation, pulmonary circulation, and then finally is exhaled through the airway. The reason I mention that, and we talk about this little journey, is because I don't want anyone to get too narrowed in, given that we're talking about breathing and respiratory therapy today, to think that end-tidal only gives us information about ventilation. Because it has to be created through metabolism in the cells, it's dependent on the metabolic rate of your patient. And because it has to be transported from those cells to the lungs to even be measured by our capnograph, it's dependent on perfusion. So yeah, when we're ventilating, most of the derangements on our end tidal is going to be related to ventilation, but don't ignore that metabolism could be playing a really big part, especially in our febrile patients. And circulation is another huge one. We have sudden drops in end tidal, that could be a perfusion emergency and not necessarily a problem with your ventilator. So just a friendly reminder on that front to not ignore those other causes of CO2 derangements on the end tidal. But what's really going to be valuable to you is waveform capnography. So this is the anatomy of a normal capnograph. So we have the start of expiration as our graph starts to increase. And this is measuring CO2, right? So that makes sense. If we have CO2 leaving the body as soon as our patient breathes out, we're going to see those levels rise. We have the alveolar plateau. So this is where the initial CO2 in the dead space, so remembering the spaces like in the trachea and the bronchi that don't exchange gases, are no longer mixed in here. And we've got CO2 most representative of those deeper lung fields, distal airways. And that's at the end of the alveolar plateau is where we're going to measure end tidal CO2. This is the point at which it's going to be most representative of arterial levels because we've gotten rid of all of those mixed gases and dead space gases. This is where your end tidal is measured. But waveform capnography doesn't just stop at end tidal. So then we have our inspiratory downstroke. So as soon as our patient breathes in, that CO2 level should go more or less immediately to zero, right? There should be no CO2 in the air that they're breathing here. And if they're taking a normal inspiration or the ventilator's delivering a normal breath, that should be a really steep drop off. And again, we can use waveform capnography to look at a lot of different things. I want to talk about what's going to be most relevant to you guys and what could be an emergency. The airway obstruction is going to be a big one on these guys. They more than likely have pulmonary pathology, or we're going to give them pulmonary pathology by putting them on the ventilator. As much as we avoid it, it happens. And those gases, even though we humidify them, can still irritate the airway, cause viscous mucus secretions. If you've got French bulldogs, they have their tiny tracheas and their tiny little trach tubes, and they obstruct very easily. So all that's to say, airway obstruction is of the emergencies, a common emergency. And I want to be able to give you guys the tools to detect it before it becomes catastrophic, because we can see it on our capnograph waveform, and it will start to look like a shark fin. So as there is more and more resistance to the ventilator delivering a breath or allowing an exhale, we're going to get a shallower and shallower curve on our capnograph waveform. And it looks more or less like a shark fin. So inspiration, because this is forced air, inspiration is forced, is usually a pretty steep drop off till it gets severe. But your exhalation is going to be a lot slower because that's a more passive process. We don't have the ventilator sucking air out of our patient. So you're going to see your obstruction there on this leading edge of our waveform. So what that looks like on an actual capnograph is this. So if you start seeing this nonsense, that's a really good time to start getting ready to reintubate your patient. Have your criticalist there to reintubate them. This is not an emergency yet, but this means that an emergency could be coming. So make sure that you're looking out for that. Really, truly, the best way to combat this is reintubation. We can suction it, and we can sometimes buy us a little bit of time before we reintubate. But ultimately with suction, we're never really going to get those like nasty, viscous, sometimes really dried and crusty secretions off the end of our tracheal tube. Any questions on the capnography here? All right, moving on to blood gases. So again, it's going to be a really big overview or broad overview. We're not going to talk about interpretation. And I'm not even going to really talk about syncing art lines or the process of doing arteriopuncture. I want to talk about sample handling and sample reporting, because I think that's going to be the most relevant to this group right now. So the supplies that you need are, most people think that you need these specialized syringes, right? In fact, you can get away with the art gases without those specialized syringes. So I don't want anyone to be afraid of not doing that because you don't have these blood gas syringes. You just need to pre-heparinize a syringe and make sure that it goes immediately into a cartridge. So I will just make a note there. And when we are doing that, because we don't necessarily have these caps available to us on the big fancy expensive syringes, you can use Crick Clay to seal your needle and just make sure you're mixing very, very well with either that Crick Clay or a cap on and putting it directly into the cartridge. So this goes for venous blood gases as well as arterial blood gases. We might be doing venous blood gases on these guys because we're looking at ventilation, which you can get from a venous gas. So even if we're drawing this from a vein, can't touch air, we have to use this anaerobic process. We have a whole SOP for this. Brooke is going to get as a part of the packet that I sent her. If you're looking for ways to draw those gases anaerobically without the specialized syringes, but certainly the specialized syringes are going to make your life a lot easier if you have them. All right, so once we have drawn our sample and run our sample, we do need to confirm that it's actually arterial, unless it came out of a catheter and we're positive that that was in an art line. So we're going to be primarily looking at our saturation of oxygen. This is going to correlate with your pulse ox. This is that hemoglobin saturation of oxygen number. If you're at 99 or 100, you're in an artery. But if you're not, doesn't necessarily mean that it's not an arterial sample. A lot of these patients are not going to be oxygenating properly, and so they might have lower SO2s. You can correlate it with your pulse ox, or you can draw a venous sample and compare them if you're just not sure you are in an artery. Most of the time, we're going to have art lines in these guys, and we don't need to take this additional step, but it's worth talking about. The other thing that I want to touch on with art gases is once we've run them, we have additional steps as technicians to take when we're reporting them in order for them to be valuable to be interpreted at all. So we don't only report the values that the machine spits out at us. We have to tell an easy vet, wherever you're recording it, we have to make sure that it's noted in the record that this is an arterial sample and not a venous one. We need to make sure that we're including the fraction of inspired oxygen. We do some calculations on the back end to determine how well our patient's oxygenating, and we have to know how much oxygen they were breathing in order to do that. One of those calculations is a PF ratio, which we're not going to go into, but if you did calculate that out, you can put that in your reporting with these art gases. And then we need our end tidal on there as well. Again, end tidal is going to be interpreted in conjunction with our arterial levels of CO2 to assess a number of things, including PQ mismatch and dead space. So we need all of this information, or this is essentially useless. The other thing that I like to report here is if anything happened prior to the art gas. Did I get an art gas because my patient suddenly crashed and I needed to know what's going on? I would report that because you're going to have massive records with dozens and dozens of art gases, and it's nice to be able to keep track of what happened and why. You're also going to get temperature corrected values. This does become important when we're talking about arterial blood gases. So make sure that you're entering an accurate temperature for your patient. It doesn't have to be the second you draw it, within about 30 minutes is fine. But the machine is going to give you temperature corrected values that you should then put into the notes section of EasyVet. Because if your patient's febrile or hypothermic, it will make a big difference. Temperature will adjust those pressures. Yeah.
Just a quick comment, we do not have the blood gas. So
We're doing things.
Yeah. And it doesn't matter if it's ISTAT or not. All the machines will do this.
yeah, it's just like do that with the vet staff, though, like you can't like put your sample directly in there, otherwise it would be disaster. Just saying.
But yes, we are going to go back
Okay.
to the ISTAT cartridges.
Oh my God.
I hate it. Well, the doctors like it better than the vet staff.
Well,
Why do you hate it?
Yeah.
no, I don't like vet staff.
Oh, okay. Yeah, no, we're going to do
I don't
ISTAT.
like vet staff. It's not super user friendly.
Yeah, the vet staff's there.
The vet stat, not the
vet
guy.
stat,
Okay.
yeah, we don't like vet
I stats all the time.
Oh, no, we don't.
We love the eye stats. The vet stats just gives us a lot of grief.
All right. So I'm definitely, as I was writing this, got sick of writing a bunch of words. And I'm sure you're sick of reading a bunch of words. So this is going to be much more conversational, and I definitely want Bridget to chime in here with her preferences. But we're going to get into the nursing care section now. Before I get into some of the specifics that I want to call out, this is not going to be comprehensive guide to nursing care, but we're going to talk about some of the important things. On these cases, nursing care makes or breaks it, 100%. I absolutely believe that. The nursing care on these guys is so intensive, and if it's ignored or done incorrectly, can really contribute to patient outcomes. And I have some examples that I can share with you. But I firmly believe that this section is going to be the most important for all of us. And it's the biggest reason why I love ventilator nursing is because I am with that patient all the time. I will also say that the nursing care that you're providing is going to be the bulk of your time on these patients. My typical cycle of nursing care for a patient takes about 2.5 to 3 hours. So I'm essentially nonstop nursing. If I'm sitting down, it's either because the patient's been on the ventilator for like 2 weeks and everything's dialed in and perfect. But most of the time on these patients, if you're sitting down, you're probably missing something. You could be massaging those legs, you could be doing oral care, you could be doing prom. The more you can do with your nursing care, the better these patients survive. That is absolutely true, without a doubt in my mind. So like I said, this section is going to be conversational. So please chime in with questions, or if you have specific preferences, I'd love to hear them. And we're just going to go therapy by therapy. So the first one is going to be passive range of motion and massage. So for patients that are on the ventilator for less than 24 hours, it's not a big deal. But we could have patients on the ventilator for 2, 3, 4, 6 weeks. Even if we're exceeding 24 hours, this does become incredibly important. So we need to make sure that we are keeping those muscles engaged and happy. Imagine, like, you guys are probably annoyed having been sitting in the same place for the last 2 hours, right? So imagine that for days on end. When these patients come off the ventilator, because they will come off the ventilator, we want to make sure that they're able to walk and they're able to move and they're pain-free, and we can get them home faster that way. So whatever protocols you have for prom is appropriate. There's nothing special about it for the ventilator. Same with massage. We just want to make sure that we are providing flexion on all of those joints, traction. If I have really long-term ventilator patients, sometimes I'll create like big bolsters so that I can place their paws in a normal position on the ground. And I had a little rig that I would do so that they could put some pressure on their paws like they're standing, even though they were anesthetized. And I would consider that to be a part of this, but don't forget how important this aspect of everything is. I'll also massage the tongue, another muscle that will atrophy and cause a lot of problems if it's not taken care of. We'll talk about oral care more specifically as well, but massaging everything on these patients can be really helpful. Again, we're going to treat these patients like they're coming off the ventilator. So if we treat them like they're going to die, they're going to die. So we want to make sure that they're set up as well as they could be for coming off that vent. So if I do have downtime, I'm massaging. Doesn't matter what, I'm massaging that patient. And then we have the competency care, which we did touch on a little bit. Typically, and again, with certain exceptions, but typically these patients are going to be external most of the time. If there are exceptions, that's likely going to be communicated pretty explicitly to you, either through Smartsheet or SmartFlow or in routes. But just because they're external doesn't mean we don't have recumbency care to do. So I will flip their up to being back. I will also adjust their hips from left to right external, from frog leg to kicking out back. So we're still adjusting their position they're in, even if they're technically just external the whole time. I will make those adjustments about every 4 hours and record them in SmartFlow so that that's communicated to the oncoming team so they know where to pick up. And then we have oral care and suction. So In this section, I have a couple pictures of horror stories. Oral care, I think, is pretty easy to forget about because it's not going to be something we typically do unless you're used to managing patients that are intubated for a long period of time. A lot of different ways to approach oral care, but the typical theory is that we want to keep the mouth moist. We want to keep pressure points from developing, whether it's from teeth resting on the tongue, whether it's from the endotracheal tube tie hitting at the commissures here, or the endotracheal tube itself pushing on the tongue. So we're keeping a really close eye out for all those pressure points. And if there is an unavoidable one, you can pack it with gauze or cotton balls. I will use mouth gags, not the dental ones, because those are too big for what we're talking about. Just need a nice little opening in that mouth so the teeth aren't resting on teeth. Some mouth gags to prevent that from happening. Glycerin, a mixture of glycerin and water, is my preferred way to keep the mouth moist. The glycerin won't evaporate as quickly, and so that can usually come to oral care every 2 to 3 hours with glycerin versus water. It's something I have to constantly remind myself to continue to moisten. And I'll use glycerin soaked cotton balls or glycerin soaked gauze to pack those areas that need to be packed. So with these endotracheal tube ties, you'll see here, I use glycerin soaked gauze on the mucosa where they're hitting the commissures. I will also adjust these. We'll talk about that, but I'll adjust these frequently too, where those ties are going. But anytime they hit mucosa, they get some glycerin. And then, you know, these pictures, like I mentioned, are some horror stories. I don't really want to scare everybody, but this is a necrotic tip of the tongue because somebody, well-meaning, but incorrect, decided they wanted to use Chlorhex to keep the mouth clean. And packed that mouth with Chlorhex and necrosed the tip of the tongue. This was an ARDS patient who was already incredibly inflammatory. And when you start having nasty infected necrotic wounds anywhere on the body in an already pro-inflammatory state, you are going to make it worse. Now, I will say this can also happen with really aggressive vasopressors. So you might see this and it's not your oral care, but in this case, it was chlorhexidine. So this is a ranula from a particularly difficult case. I think they had a lot of trouble getting it on the vent and getting it anesthetized, ended up having to use paralytics. Long story short, oral care was delayed. I initiate oral care as soon as my patient's stable. And he developed this big old ranula, and it became so progressive that we delayed extubation because he had that ranula. So this is something that tongue massage can help prevent. Really want that tongue moving. If they're not going to move it themselves, you move it for them. But also packing with glycerin and keeping everything moist. And then this is where somebody pulled dried out gauze from off the bottom of the tongue. So it packed the mouth appropriately. I don't know if they had a glycerin and water mixture, just water here, but they were going to change all of those gauze squares and pulled that off and ended up ripping off a couple layers of mucosa here. And that was a challenge to get to heal well while also still fighting our typical oral challenges in these patients. So don't skip oral care. I say this because I see a lot of people deprioritize it, and it's not more important than the life of your patient, but it's still very important. And then we're suctioning the mouth as well. So every time we pack it, we're also going to suction. We're going to suction all the way to the back using those Yankauer suction tips, potentially suctioning out the proximal esophagus. And then scrubbing every tooth as well, like toothbrushing, but with glycerin. I just take some hemostats and a cotton ball soaked in glycerin and brush every surface of that mouth. Hard palate, under the tongue, cheeks, all of it. Keep that mouth nice and clean. That's my general approach to oral care. Seen people like go crazy and like pack the entire mouth. Seen some people who just like to use a little bit of gauze. I think as long as you're just conscious and aware of your patient's oral care, whatever you're doing is going to be fine. Because I've had success with both methods. And I do really think it just comes back to an awareness that this is important and we should address it as opposed to ignoring it completely. And then we have endotracheal tube care and suction of the endotracheal tube itself. Usually in these patients, and Bridget, you might have a different frequency on this, but we'll sterilely reintubate once a day. potentially more if they've been obstructing their endotracheal tube frequently. So that should be something that is on your treatment sheet and something you should plan for. If we're not re-intubating, we still have endotracheal tube care to consider. So about every 4 hours, we're going to deflate that cuff and we're going to adjust the position of that endotracheal tube by a small amount so that that cuff's not applying pressure in the same spot on that trachea for the entire duration of their ventilation. We are also going to adjust where those ties are lying. So I have like this little bonnet thing on this guy here. Sometimes if my patient is particularly anesthetized and I know I'm right there, I will leave that completely untied until I walk away and have to do something else to just make sure that, again, we're not putting pressure in the same spot for the duration of their ventilation. Making sure that your cuff is not overinflated is also very important. So if you don't have the little cuffulator manometer things, strongly recommend them because we're not pumping these cuffs up like we would for an anesthesia. They're gonna be just enough to get a seal. And then we do need to suction through this endotracheal tube every 4 hours as well. Depending on the patient, you might be suctioning into the bronchi themselves. That is certainly a criticalist decision. Now, suction is something that we can absolutely do, but it has to be super sterile. Sorry, Brooke, did you? Oh, okay. It has to be super sterile. And we can introduce some patient complications if we do it incorrectly. So I would be trained by Bridget. If you are going to do this, there's no reason you can't when you're trained properly. That usually is going to occur every 4 hours as well. But again, that might be very patient specific. If they have a lot of secretions, we might be doing it more often. If they don't, we might be doing it less frequently. Something we don't often think about that comes out of left field for me all the time is how the heck do we weigh these patients? It is so frustrating and it's a huge process for something so simple. So I do want to spend a couple minutes on that. It is incredibly important that we get patient weights on these guys because we're watching fluid balance in them very, very, very closely, especially if they're congestive heart failure, but in all cases. And so accurate weights occurring every 6 to 8 hours is important. It's just a huge pain. Usually it's going to take 2 people to weigh a patient, and you have to be super organized and super communicative. And when I'm working with people for the first time, I think they get really irritated with me because I spend about 5 minutes talking to them before we weigh them. And then they figure out why I spent 5 minutes talking to them. So you're going to have to organize all of your lines to make sure you know what can be taken with you when you're weighing that patient and what can't. You want to keep monitoring on them if you can. And you want to be able to weigh them close to the ventilator without extubating them. What I like to do, we found baby scales at the practice we vented a lot at that could weigh up to, I think, 150 kilograms. Like they were little, but you could stand on them with a patient. And I would organize all my lines so I didn't have to disconnect anything. And I would just awkwardly like kind of stand over if my patient was small enough and get a weight that way. Not everybody's going to be able to do that. You have those hydraulic tables that have weights. You could slide your patient over to that table and weigh them. However you need to weigh them is going to kind of adjust how you set up weighing them. But my biggest tip to you is if they have to be disconnected from the ventilator or they have to be disconnected from monitoring, you better be really organized before you take that patient off of that monitoring equipment or off of the ventilator because you want to be able to get them back on right away. And that would be a case where you'd use your O2 boost button to give them 100% oxygen before we're going to disconnect them. If you have to travel somewhere to weigh them, make sure you have at least an ambu bag so that you can breathe for them as you're traveling. All right, organization and line management. A lot of these guys have absolutely insane amounts of CRIs. And nothing drives me more crazy than tangled lines and a bunch of lines going into a bunch of random ports and random catheters. It doesn't make sense. So I'm not going to tell you how to organize your lines or what ports you want your lines to go into. Just make sure that your lines are clearly labeled and there is sense to it. Please don't put midazolam Y-ported way up high on an extension set. It's going to precipitate by the time it gets to your patient. That has to be a super proximal port or directly into the T-port. And then I typically will like vet wrap my sedative lines together, all individually labeled, of course, but then I'll vet wrap my pressors together, my fluids together, my blood products together, so that I can really quickly access where all of them are going, especially when you get like your 9 pump and up cases. Definitely want that. On that note, strongly recommend a bolus bag in your bag with KCl. Like, make your life easier, have pumps for everything. Even if you're not using them all the time, you do not want to be like tracing lines when you've got all of those things. Just hoard your pumps, have them all set up, and then you can run them when you need to, and it's not a big production. So on the back end of that, organization generally is incredibly important for these guys. So by organization, I mean you should have every single thing that you're going to need for that patient for a 24-hour period accessible and visible and organized. So this, of course, includes emergency drugs. I usually have a dose of atropine pulled up because we can bagel the crap out of our patients with suction. So I will have that dose pulled up. I will have a whole intubation kit ready to go. So just everything you need for intubation, including a pre-drawn induction dose. Now, do you guys treat propofol like it's controlled here? Okay, so it'll be a little bit easier for you than in some other places. But I like to have that pre-drawn induction dose. If I do throw it, like if I do have a problem, like a complete endotracheal tube obstruction, I don't want to have to worry about where my propofol is, or, oh my gosh, I don't have the right size syringe. I just need to be able to give it. And then I have supplies for all of my treatments as well. Just all set up and organized so that I can just continuously rotate through my day. So what that looks like for you is going to be pretty individual based on your preferences. What it looks like for me is commandeering a table and having everything super set up and labeled. And then we are also cleaning the entire room every single day. So wherever you're ventilating, tape off an area. Your ventilator needs to be wiped down. Your table needs to be wiped down. Your bedding needs to be changed. Your garbage is emptied and wiped down. Your suction emptied and wiped down every single 24 hours. These patients are immunocompromised, super prone to pneumonia. Whether or not you're ventilating in a separate room or in the middle of the ICU, you have to do all of that. All right, and finally, just a really brief talk about complications that we should be on the lookout for. Yeah, there are a million complications with ventilation, but these are the ones that we're going to be looking at, especially with your smart machine that's going to tell you what the alarm is and how to fix it. I don't really have to do that. But I do want to talk about patient ventilator asynchrony, or bucking the ventilator. This can be caused by a number of things. In all cases, it should be avoided. So these patients can get diaphragmatic injury as a result of fighting the ventilator when they're trying to exhale and the ventilator's trying to inhale, for example. But more importantly, they're not going to allow the ventilator to actually do what they need. So this can be caused by a number of things. The scariest one is going to be hypoxemia. When oxygen levels in the blood drop really, really, really low, and oxygen becomes the primary driver of respiration as opposed to CO2. Doesn't matter what you do to these patients, doesn't matter how much propofol or alfaxolone or whatever you're using you give to them, they are going to be panting because their respiratory drive is just that severe. Those patients are usually ones that we're paralyzing. Whether or not you do that, it's really an institutional preference. But don't forget that like really bad hypoxemia can cause them to pant against the ventilator no matter how much induction drug you give them. So if you're noticing they're eating up that propofol, look for hypoxemia. Hypercapnia, just to back up, hypercapnia can also cause patient ventilator asynchrony, so elevated CO2 levels. We can see that with a pneumothorax. We can see that with elevated body temperature. Also with inappropriate ventilator settings. If we're not supporting them well enough with the ventilator, they're going to try to support themselves on their own. But most importantly, and probably most commonly, it's just inappropriate anesthetic depth. Just anesthetize them. They just need more drugs. It's almost always going to be the case. All right, endotracheal tube obstruction we talked about, but this is something that we should always be looking for. Vasovagal reflex, particularly with suction, but a lot of these guys are going to have high vagal tone generally. So this can absolutely happen with suction. In fact, almost always does, especially if we're going, kind of into the deeper airways. So have your atropine dose drawn up and ready. And then hemodynamic compromise, not only because these patients are typically very sick, but because the ventilator itself can cause hemodynamic changes, especially if we're running with really high levels of positive end expiratory pressure or PEEP. So the chest isn't meant to have positive pressure driven into it. So when we do drive pressure into it with a ventilator, it's going to compress venous return to the heart, reducing preload, which means reducing perfusion. Usually volume is what we need to fix that. But if we're running really aggressive ventilator settings, then we might walk it back a little bit as well. Okay, we did it. This is Cosmo, by the way. He was one of my favorite vent patients. Yeah, he's a good boy. He's in Boston now, living his life. What questions do you guys have about ventilation? I hope I didn't shell shock anybody. I was definitely not that thorough. I know I wasn't. Do you have anything to add?
I think the biggest to add is just that, like, I feel like when we have owners commit to ventilator patients, like trying to likewise commit, even though, like, sometimes they're not the best patients, or sometimes they're just committing, like, because you can't let go, or like I've had a scenario where like they're out of time, just trying to get that to where they can do that. Like sometimes they don't always understand the reason, but committing to them and creating a positive environment around it, even in the cases that you don't think are going to go that great, helps with like improving your learning with that patient or one that might be amazing. So just kind of try and approach it with a positive attitude, because you're going to retain more, you're going to learn more, and it's going to be a better environment for you to like do a bunch of challenging but great nursing care.
And these guys get all the good drugs. Ventilation's uncomfortable, but it's not painful. So we give them lots of good stuff, and we make sure that they're comfortable too. So that's the other thing. We're not cutting them open.
Much better than watching them sit in the O2 panel, just chugging away forever while.
Yeah, I truly believe that if you approach these advanced therapies like you think they're going to work, they will. You approach it like the patient's going to die anyway, they will. Have you seen them? A fair amount. I mean, clearly not as much as dogs, but maybe like 20 or 30. Successful ones, they have a lesser success rate than dogs for sure, in my experience. I would maybe say a third